Okay, committing other. Yeah. So as you saw on the topic, it's about transplantation and indications and care of the post-transplant patient. Presenter is Sipho. Um, when do we think the India Echo people
We can
can
do that at the end, don't
decorate
worry.
with it? Okay, very well. So yeah, over to you then, Sipho. Unmute.
Hi, everyone. Has the session started?
Hello, Bilal. We already said hello to everyone. Neo stepped in for a moment, and Sipho's about to share his presentation.
Sorry. Okay. Hi, everyone. Sorry for being a little late. Sipho, you go for it. You've got a little halo around your head. You know that. It's the clock that's behind you.
Oh, can you see my slides? Can you see my
Yep.
slides?
Yes, we
Yeah, we
can.
can.
Just tell me, Karen, if it's the correct one.
We don't see your notes, so go ahead.
Okay, let me just
All good.
okay. Oh, sorry. Let me just sorry, 1 minute. Just gonna go to the presenting mode again. No.
That's it. We see your first slide.
Perfect. Good evening, everyone. Thanks for joining the G-ECHO presentation, and thanks to Project ECHO for this opportunity. My name is Dr. Sipho Nkandlalalana. I'm a fellow at Johannesburg at Charlotte Maxeke and Wits Donald Gordon Hospital. And thanks to Karen as well as Dr. Bilal for guiding me on this presentation. Tonight's presentation is on liver transplant. So this is the outline of the talk today. I'll go through epidemiology, indications and contraindication to liver transplant, as well as I'll also go through liver transplant evaluation, immediate postoperative management in the first week, and I will also have a brief talk on immunosuppression in liver transplant. Liver cirrhosis is responsible for 2.4% of global deaths. That was in 2017. And this was a rise from 1.9% from 1999. There were 10.4 million cases of decompensated cirrhosis globally in 2017. And the major causes of liver cirrhosis globally are hepatitis B virus, hepatitis C virus, alcohol, hepatitis, osteoarthritis. Also of recent, there's been a recent rise in steatotic liver disease. And this really occurs with gender variation. And the overall survival post steatotic liver transplantation is 90% at 1 year, 80% at 3 years, and 75% at 5 years. And liver transplant need is rising with cirrhosis burden. There were 94,694 liver transplants globally in 2021, which was an increase of 20% from 2015. Stats from our local center in South Africa at Wits Donald Gordon Hospital. In the past decade, these were stats from 2012 to 2013. It showed that there were around 725 liver transplantations which were performed. And amongst these, a total of 196 were living donor livers, and this occurred over the same liver transplant. This was inclusive of both a pediatric as well as adult liver transplant. In the United States, there were more than 9,400 transplants, which occurred a year. And there's also a rise in living as well as high-risk donors. Whereas in Asia, there's predominantly living donor liver transplants. In the United States, the living donor liver transplants are still low. They were at 4.3% in 2020. This is just an illustration which shows the global liver transplant activity in 2021 per population. There were overall about 34,944 liver transplants which were performed. And the highest number was noted of liver transplant per million population. They were mostly seen in Korea, as well as in the United States and in some parts of the Western world. So we're still far behind in Africa and in smaller countries. 1 year after liver transplant, the patient survival is approximately 91%, while graft survival stands at around 89%. These outcomes have improved due to advancement in surgical techniques, better patient selection, and more effective immunosuppressive therapies. And the leading causes of death within the first year post-transplant are often unrelated to the liver function. And these include malignancies, cardiovascular disease, infection, and renal failure at 6%, being the most common causes of death within the first year post-liver transplant. And beyond the first year, metabolic syndrome becomes a significant concern for patients post-liver transplant, as far as morbidity and mortality are concerned. Indications for liver transplant include an acute liver failure, which is defined as the development of severe acute liver injury with encephalopathy, with impaired synthetic function, defined by an INR of 1.5 in a patient without a pre-existing liver disease, and with an illness duration of less than 36 weeks. And the most common causes of acute liver failure include viral as well as drug-induced hepatitis. Patients with acute liver failure who fulfill King's College criteria are given the highest priority. This is based on the UNOS status 1. Acute liver failure patients should promptly be referred to a liver transplant center as soon as possible due to high rate of mortality and associated morbidity with delays. As far as liver cirrhosis and liver transplantation, liver cirrhosis solely is not a sufficient indication to warrant a liver transplant. Typically, these patients with liver cirrhosis are candidates for liver transplant once based on the MELD score. If the MELD score is 15 and above, these patients can be listed for transplant if they deemed suitable based on the evaluation. Usually transplant evaluation is initiated once the MELD score is above 10. This allows adequate time for the patient to complete pre-transplant evaluation. Liver transplant qualification is considered in some liver cirrhosis complications and in the presence of conditions that qualify for standard MELD exception points. This is despite the MELD score, or even if the MELD score is less than 15. Some of the conditions which qualify for MELD exception points include hepatocellular carcinoma, which is within Milan criteria, or which has been downstage to Milan criteria, or which meets other criteria, such as the UCF criteria, and there are other criteria, but we commonly use here in South Africa the Milan criteria as well as UCF criteria. Hepatopulmonary syndrome is another condition that qualifies for mild exception point. Portopulmonary syndrome with a mean arterial pressure of less than 35 millimeters of mercury on treatment. So the patient needs to have responded to treatment. Cystic fibrosis, hilar cholangiocarcinoma with a size within 2 to 3 centimeters. This has been said that if the center has agreed to use the UNOS approved protocol, this protocol consists of therapies such as neoadjuvant and adjuvant chemotherapy, pre and post-transplant. So in centers which have agreed or adopted this UNOS approved criteria, which will allow these patients to be listed for exception points. And hepatic artery thrombosis, this post-transplant said within 14 days post-liver transplant, these patients will qualify for exception points. And there are some conditions which could be considered for exception points based on the center. These include recurrent cholangitis in patients with primary sclerosing cholangitis who are on antibiotic suppressive therapy or who require repeated biliary interventions. Refractory ascites to therapy, refractory hepatic encephalopathy, refractory varicose hemorrhage to medical as well as endoscopic therapy, portal hypertensive gastropathy leading to chronic blood clots, intractable pruritus in patients with PBC who have failed all medical modalities. These patients could be considered for exception points. These are contraindications to transplant based on the recent USL guidelines. These include cardiopulmonary disease that cannot be corrected, and that is prohibitive to risk. That is a prohibitive risk for surgery. This includes an unrevascularizable significant coronary artery disease, which is defined by more than 50% or more stenosis in one or more segment of the 3 major coronary arteries, or more than 70% stenosis in moderate size branch vessels. And this has been said to be an absolute contraindication to liver transplant due to a high risk of 3 months mortality associated with this condition. Patients with mean portal arterial pressure of more than 45 millimeters of mercury, despite vasomodulator treatment, should be considered as to have an absolute contraindication to liver transplant. Malignants outside of the liver not meeting oncologic criteria for cure, hepatocellular carcinoma with metastatic spread, that includes a portal vein tumor, is an absolute contraindication to transplant. Hemangiocarcinoma, anatomic abnormalities that preclude liver transplantation, patients with uncontrolled sepsis during listing, patients with acute liver failure with sustained raised intracranial pressure of more than 50 millimeters of mercury, or a cerebral perfusion pressure that's less than 40 millimeters of mercury. Patients who are non-compliant to medical checkups or medical care that precludes those patients to liver transplant despite interventions as far as the social worker, as well as the psychiatrist, as well as interventions from the whole medical sort of liver transplant team. Patients with lack of adequate social support, that's been deemed that can be considered as there's a preclusion criteria to transplant due to a higher risk of relapse or poor compliance to therapy and higher risk of complications post-operatively. Pre-transplant evaluation is a multi-disciplinary team evaluation. It includes a team that consists of a cardiologist, a pulmonologist, a transplant surgeon, a hepatologist, an intensivist, a social worker, a psychiatrist, a dietitian, as well as support system and a caregiver for the recipient. Candidacy assessment includes a MEL score, as well as cardiopulmonary assessment, frailty assessment, which the most commonly used frailty assessment internationally at the moment is the liver frailty index, which has been shown to have a high 3-month mortality, which showed a high 3-month waiting list mortality, as well as the sarcopenia assessment based on the skeletal muscle index using a CT imaging. Nutritional assessment from a dietitian, as well as anatomical and surgical factors play a role, as well as a screening for occult malignancies. Also, during pre-transplant evaluation, these are the standard bloods that are done, and as well as there could be additional bloods based on the comorbidities as well as the underlying liver disease on top of these bloods. And this includes your blood typing, liver biochemistry, urea and creatinine, as well as sodium, serum alpha-fetoprotein, as well as your calcium and vitamin D levels and your serology, as well as urine and urine drug screening. As far as cardiopulmonary evaluation is concerned, all candidates who are being considered for liver transplant must have a minimal cardiology evaluation, and this consists of an ECG as well as cardiothoracic echo, regardless of the baseline comorbidities and age. And the following risk factors are used to identify patients with high risk for coronary artery disease, which includes an age above 60, male gender, BMI of more than 30, diabetes, dyslipidemia, smoking, history of hypertension, history of coronary artery disease, or family history of coronary artery disease, patients with left ventricular hypertrophy, renal disease, transplant patients with a transplant indication of MASH, which is metabolic dysfunction associated steatotic hepatitis. These patients have been deemed to have risk factors for coronary disease. And these risk factors guide the diagnostic strategy for identifying patients who are at risk for coronary artery disease. There's what has been devised as a coronary artery disease liver transplant score, which uses these factors to predict significant coronary artery disease. It has been said that patients with 2 of these factors plus MASH are at high risk for coronary artery disease, or patients with 3 or more of these factors have been also classified as having a high risk, as to be high risk. And this has been used to guide the need for further invasive diagnostic evaluation. The other test that we use in cardiopulmonary evaluation is cardiac stress testing. This is done in patients over the age of 40. It is also done in younger patients who are younger than 40 with multiple risk factors for coronary artery disease. Pulse oximetry as well as an arterial blood gas. And in patients with suspected valvular heart disease or hepatopulmonary syndrome, as well as portopulmonary hypertension, these patients are evaluated using a transthoracic echo, as well as a bubble test. A chest radiography to exclude pulmonary diseases, And depending on the baseline respiratory or pulmonology workup, contrast enhanced CT chest as well as a pulmonary function test with DLCO may be advised with consultation with a respiratory specialist. On the right, the flow diagram on the right just further stipulates a workup of liver transplant as far as cardiovascular is concerned. So in patients with, so the question is does the patient have an established heart disease? If the answer is yes, the patient should straight away be referred for cardiology referral. If the patient does not have an established heart disease, you do a baseline ECG as well as a transthoracic echo. If it's normal, you look at your risk factors for coronary artery disease and whether the patient has got diabetes mellitus. If the patient has got none of these, then the patient may proceed for listing, and then with repeat ECGs and echo based on the wait list duration. If the patient does have coronary artery disease risk factors and is also diabetic, the patient may proceed for further evaluation. You can either use a less invasive form, which is a coronary computed topography angiography or CT angiography, which has been shown and recommended in the recent guidelines, in the usual guidelines. Or if there's patient has got more risks for coronary artery disease, these patients can be evaluated directly with invasive coronary angiogram. And if this is positive, I guess at this stage, patient would have been seen by a cardiologist anyway. This is just a summary of how to work up as far as cardiology is concerned, because not everyone, and it also helps you to navigate which patients require involvement of a cardiology. With further transplant evaluation, we screen for cancers. We use a contrast-enhanced abdominal CT scan as well as MRI. This also evaluates for the presence of hepatocellular carcinoma. You can do a skin examination clinically in these patients, as well as a screening colonoscopy. It says that in some centers based on age and risk factors. Also, in females, you screen for cervical cancers with a pap smear, as well as breast cancer screening for females. For males, you can do a PSA as a screening tool in patients with low risk factors for prostate cancer. And if there are risk factors or symptoms, you can involve a urologist for further evaluation. Also, you screen for infections prior, and you can do a skin testing or interferon gamma release assay for tuberculosis. In preparation, these patients post-transplant require high doses of immunosuppressive therapy. You also send these patients prior to during evaluation for dental evaluation. And in high endemic areas, you also screen for fungal sort of infections such as coccidioidomycosis, and you can also screen for strangulodiosis. But this is based on endemic of the disease. Evaluation also includes a psychosocial evaluation, which includes a psychiatrist, a social worker evaluation, also patient education seminars. We also evaluate for substance use disorders such as drugs and alcohol. Other tests include bone density scan especially in patients with autoimmune diseases such as autoimmune due to a long-term exposure to corticosteroids. You can also do a abdominal ultrasound with Doppler imaging to assess hepatic vasculature. This is usually done in younger patients with low risk factors, especially in patients being evaluated for status 1 transplant. Also, with your colonoscopy, you can also do upper endoscopy. Also, you also do endoscopy to screen for varices in patients with cirrhosis or portal hypertension pre-transplant. And with that, you also do eradication therapy endoscopically. in terms of surgical, in terms of perioperative complications, I've divided them into surgical as well as medical perioperative complications. Surgical complications include severe intraoperative hemorrhage, bleeding, abdominal drainage, cardiopulmonary instability, hepatic artery thrombosis, portal vein thrombosis, biliary leaks or strictures, hepatic artery stenosis, and ischemic biliopathy. Perioperative medical complications include graft ischemic injury, reperfusion injury, primary non-function of the graft, bacterial infections, immunosuppressive drug side effects, acute kidney injury, and acute liver allograft rejection. Further discussion of surgical complications. Biliary anastomosis, there's two types. There's duct-to-duct anastomosis, as well as Roux-en-Y cholecystectomy, which is commonly done in patients with PSC. These have been said to have a similar rate of complication post-transplant. PSC patients, as I already mentioned, cholecystectomy jejunostomy is the most preferred anastomosis. The most common biliary complications include biliary strictures, which could be anastomotic or non-anastomotic due to ischemia. They also include bile leaks, biliary stones, and casts. Bile leak incidence has been reported to range from 2 to 25% after liver transplant. Bile leakage can result from the cut surface of the liver or from the site of anastomosis. And bile leaks occur in up to 10% of donors. It has been said that right liver graft recipients have higher rates of complications compared to left liver graft recipients. Clinical presentation of patients with bile leak include fever, chills, abdominal pain, elevated liver enzymes, and the diagnosis of bile leaks include a HEDA scan, which is a non-invasive test with good accuracy. We can also use cross-sectional imaging, such as a CT scan or an MRI, which might reveal a biloma. In patients with equivocal findings, we can do an ERCP as a diagnostic as well as a therapeutic intervention. In terms of therapy for bile leaks, ERCP with sphincterectomy and stent placement is a modality of therapy for all cases with bile leaks. And a repeat ERCP for stent removal or exchange is done in 2 to 3 months. And due to slower healing in liver transplant patients, stents are kept for a longer duration compared to those placed for bile leaks following a cholecystectomy. For large biliary collections, a percutaneous drainage may be required, and surgery is really reserved for non-responsive or refractory cases. Another surgical complication is biliary strictures. Clinical manifestations. These patients are most commonly asymptomatic. They usually present with elevated liver enzymes, and they also present with non-specific symptoms, which include pruritus as well as jaundice. And the workup starts with a Doppler ultrasound to rule out a hepatic artery thrombosis. The next slide of next line of investigation is MRCP and then ERCP, and then in patients with previous cholecystectomy strictures, PTC is a modality of investigation. Treatment is ERCP with balloon dilatation to 6 to 8 millimeters, which is followed by stenting and this has been said to be the treatment of choice. for patients with duct-to-duct anastomotic strictures. And ERCP is repeated every 6 to 8 weeks with a maximum of 3 months. And most patients need 3 to 5 ERCP sessions to achieve target. Other therapeutic options during ERCP include placement of multiple plastic stents or placement of a fully covered metal stents. And plastic stents are the most commonly sort of used. Moving on to another peri-operative medical complication, which is the most widely, known as far as the liver transplant is concerned, is liver allograft rejection. This is classified based on the BAFNI liver working group into early T-cell mediated rejection, as well as late T-cell mediated rejection, and into chronic rejection, which is further subdivided as per following slide. So the BAFNI liver working group is based on histopathology staging as well as grading. As I've already mentioned, there's T-cell mediated rejection, which is further divided into early or late T-cell mediated rejection, as well as chronic rejection, which is also divided into early chronic rejection and late rejection. You also have plasma cell rich, and antibody mediated rejection. And obviously this is important because based on histology, because treatment of these different is different. Treatment of these is different. Risk factors for rejection depend on the underlying liver disease. Patients with autoimmune underlying liver pathology are more prone or are more susceptible to develop rejection. These include AIH, PSC, and PBC, patients with CMV infection, obviously patients with non-compliance to immunosuppressive therapy, they're at higher risk of rejection. And some of the risk factors are donor or recipient dependent, based on the demographic of the recipient or donor. These are the differential diagnoses to patients with abnormal LFTs post liver transplant. So differential diagnosis to acute and chronic rejection. So they include most of the conditions that I've already alluded to. And then they are really divided again to surgical issues as well as infections, and it could be rejection itself. Here it's a treatment algorithm for rejection in liver transplantation. So treatment depends on the type of rejection, whether is it a T-cell mediated, acute versus chronic, or whether it's antibody mediated rejection, and therapy is guided by histology. So in patients with T-cell mediated rejection, the first line of therapy is glucocorticoids, and treatment is escalated based on response. And in patients with antibody mediated rejection, as opposed to T-cell mediated rejection, first in acute antibody mediated rejection, the first line of therapy is plasmapheresis and your IV immunoglobulins, as well as your rituximab, and we can also use botulismab, as well as eculizumab. As far as the chronic rejection is concerned, you can use immunosuppressive therapy, such as your CNIs, most commonly your tacrolimus, as well as you can use the mTORs, which is everolimus, and you can escalate therapy based on response. In terms of management, this is a sort of an overall guide to management of patients to post liver transplant. And you can really divide into sort of immunosuppressive therapy, psychosocial, post-transplant metabolic complications, as well as screening, including cancer screening, and based on surveillance for graft function. Under psychosocial, can address habits such as alcohol cessation, smoking cessation. Under psychosocial, you look at quality of life and improve patients' quality of life post-transplant. Make sure patient can go back to employment, as well as improve sexual health, as well as physical activity. You also monitor these patients because they are at high risk for metabolic complications, and as a consequence of can either be from immunosuppressive therapy post-transplant, and these include diabetes mellitus and hypertension, which could be a therapy morbidity, steroids, as well as immunosuppressive therapy. You address obesity, as I've already discussed. Some of these patients are at high risk for coronary artery disease, as well as osteoporosis surveillance using a DEXA scan. And then in terms of immunosuppression, you ensure compliance. To therapy, and this really begins pre-transplant, during transplant evaluation, during patient education, immediately post-transplant, and going post-transplant. So it's an ongoing process. And then therapeutic drug monitoring, as well as dose adjustments post-liver transplant, and be aware and monitor for drug interactions as well as side effects. And also consider pregnancy in women of childbearing age. This is very important because, as we all are aware, some of these immunosuppressive drugs are teratogenic. So you might have to adjust therapy, and you really look closely for immediately post-transplant for complications which I've discussed, such as rejection. And especially in the first 6 months of post-transplant, these patients are at high risk for infections, and as well as disease recurrence, depending on the underlying liver pathology. And you continue your cancer screening. Some of the drugs are predisposed to increased risk of cancers, such as your such as the calcineurin inhibitors, as well as antimetabolites, if the patient is in one, such as azathioprine. These patients are prone to certain cancers. So it is important to surveil these patients for treatment complications. Liver transplant immunosuppression therapy. So it's divided into induction therapy, as well as maintenance therapy, as well as surveillance or maintenance therapy. Generally, induction therapy in most centers starts on the table, when the patient is on the table. And this may be in the form of, this includes a glucocorticoid. Induction therapy includes IV glucocorticoid therapy, as well as most commonly used is IL-2 receptor antagonist. In our center, which the one that we use is basiliximab. This can be used in combination based on high risk factors for the patient, or in some centers, they will use IV glucocorticoid as induction therapy. In terms of maintenance therapy, generally maintenance therapy includes 3 drugs, which I will discuss on the following slides. And to re-emphasize, medication adherence is very important. Again, at this stage, patient education, to ensure access in terms of cost and transportation. The patient is aware of the medical labels, knows the drugs very well, and really you do a close follow-up. In the perioperative period, especially in the first 3 months, you might be required to see the patient regularly. It's been said that you're required to see the patient every week, and over time you may extend the visit periods. as well as you might be required to see the patient sooner if you're going to change immunosuppressive therapy. Further discussion on immunosuppression therapy. Immunosuppression therapy is really a balance between preventing rejection and minimizing side effects. And most centers use a triple therapy regimen to start with. And this has been said that it's center specific in terms of which regimen each center, it might differ center to center. But the generally accepted regimen consists of a glucocorticoid therapy, which is IV in the first week, and then the second week a transition to oral and to a lower dose. And the second drug is your calcineurin inhibitor. The most common one that's used is tacrolimus due to its higher potency compared to cyclosporine. And the most commonly used antimetabolite is mycophenolate mofetil. But in patients who are intolerant to MMF, we can use myfortic or azathioprine. Also in patients, bear in mind in patients of childbearing age, the MMF is teratogenic. You might have to use azathioprine in these cases. This is a glucocorticoid dosing after liver transplant. As mentioned in the first week, you used high doses of methylprednisolone, and after a week, obviously depending on patient response and recovery, and how stable the patient is biochemically, you then transition the patient to oral lower doses of glucocorticoids. And glucocorticoid therapy is used for 3 to 6 months traditionally, and can then be weaned off. But bear in mind, there are conditions which might require a prolonged duration of glucocorticoids, and these may include an underlying autoimmune condition, such as autoimmune, where you might require more prolonged glucocorticoid therapy. Patients of prior rejections, those are sort of some of the conditions where you might be required to continue low dose steroids with monitoring of steroid morbidity. As far as tacrolimus is concerned, as a second backbone therapy, this is the recommended target trough level. This is based on the USL guidelines. So in the first 4 weeks, you use the target trough is 6 to 10 nanograms, and beyond 4 weeks, you lower based obviously on if the LFTs are stable, you may then lower your target trough level. And as I've already mentioned, the target levels may differ in some conditions, such as autoimmune, prior rejection, patients with ABO incompatibility, in patients with chronic liver disease, where you might require to use lower doses of tacrolimus. And it's been said that in patients with chronic liver disease, that's when you might use that IL-2 receptor antagonist, basilicizumab, as induction. That will sort of protect you or allow you to use lower levels of tacrolimus or lower target levels. So it's been said in such conditions you can use basilicizumab as an induction to sort of cover your immunosuppression. These are the core immunosuppressive drugs that are used post-liver transplant, and these include your glucocorticoids, and it's important to know the side effects and toxicity of these drugs, and your calcineurin inhibitors, such as cyclosporine, tacrolimus. But in terms for the liver, we usually use tacrolimus, as well as your mTORs. But the most commonly mTOR that we use is the certican, everolimus, which has been said that it should be used after, it's safe to use after 1 week post-transplant. And if you require to use sirolimus, you can only use it after 1 month post transplant due to higher risk of complications perioperatively. MMF as the most commonly used antimetabolite, as well as these are the side effects. They include GI side effects, which some patients are prone to, and you might be required to switch to another antimetabolite, such as azathioprine. As well as I've already mentioned, we also used as induction therapy, your Simulect, which most centers use 2 doses during induction. And it is important to note these important side effects which occur quite commonly and can pose a major morbidity to patients. So during follow-ups and in clinic, you should always screen patients for all these side effects, as well as drug interactions. As this next slide. So it is important to note treatment interactions. These are the most common interactions to MMF. Drugs that increase drug levels include your antivirals, as well as other drugs which are for neurological conditions. And these are some of the drugs that decrease your blood levels of your MMF, include antacids, such as your magnesium hydroxide, antibacterials, metronidazole, as well as your iron supplements, which are commonly prescribed or patients use them as over-the-counter medication. And some of drug interactions to tacrolimus include antifungals, antibacterials, which are mostly commonly prescribed. These include your clarithromycin, azithromycin, and levofloxacin, as well as some foods, including grape juice, as well as you mostly prescribed calcium channel blockers, such as your nifedipine. And in the setting of HIV, be aware of drug-to-drug interaction with your ARVs. These are said to increase your tacrolimus levels. So you should be aware and adjust appropriately in these patients. And on the right is some of the drugs that decrease your levels. These include your antiepileptics, as well as your antibacterials, some of the TB drugs, and some herbal sort of preparations. So it's important always to interrogate and get more history in patients with labile trough levels. Oh, sorry. My slides are not moving. Sorry. Sorry about that. Screen is just acting up. This is one of the most important post-operative complication, especially in the first 6 months post-transplant. These include opportunistic infections, such as aspergillosis, pneumocystic jirovecii pneumonia, CMV, HSV, and nocardiosis. And there's also a high risk of reactivation of your Mycobacterium tuberculosis during this period, especially in patients with high doses of immunosuppressive therapy. And these patients are also at risk of recurrence of hepatitis C, as well as your hepatitis B infection. And also these patients are prone to also bacterial sort of infections. And post 6 months post liver transplant, patients are less prone to these opportunistic infections, and they might have sort of a global sort of infection. They might be prone as the general population. And post, especially in the first 6 months, in the first 3 months, post-liver transplant, these patients we require to put them on prophylactic agents, and these include Bactrim, INH, which as well, which is not mostly used, as well as in some centers, if there's availability, valganciclovir. If there's no access to valganciclovir due to finances, you might be required to do regular CMV viral load monitoring. So I think we're almost at the end. As far the other most common post-transplant infection is CMV infection. And patients are categorized as based on the following: whether the patient has got CMV disease or whether the patient has got CMV viremia post-transplant, and whether the patient, and based on the donor as well as the recipient serology. So if the recipient has got CMV disease and is symptomatic from CMV infection, that patient requires treatment with IV ganciclovir. Then it can convert to oral valganciclovir to complete the course. And in patients with CMV viremia, it's based on the first look at the patient, as well as we look at the donor as well as the recipient serology pre-transplant. And if the donor is positive and the recipient was negative, in terms of surveillance of CMV viral load, you do it in 3 days. And if it's detected on the recipient between 1,000 and this is between 1,000 and 3,000, you may require to start the patient on oral valganciclovir. And if the donor is positive, the recipient was negative, and the repeat viral load every week. And if the repeat viral load is more than 3,000, you treat the patient with oral valganciclovir. And if the recipient is CMV serology positive and has CMV risk factors, you repeat viral load weekly. And if the viral load becomes detectable between 1,000 and 3,000, you start the patient on oral valganciclovir, as well as obviously if the viral load is higher than that, you also treat the patient with oral valganciclovir. If the recipient is got serology positive, you do viral load every week. If it's if there is between 1,000 and 3,000, you can no treatment is required, and then you monitor and retest. That's if the donor sort of serology is unknown, and if obviously it's more than 3,000, you can then treat the patient. This is the protocol that we use locally at the Wits Donald Gordon Center for our CMV sort of monitoring post-transplant. I think that was my last slide. These are some of the references that I've used in preparing for this overview of liver transplant. Thank you for joining.
Yeah, thanks, Sipho. Opening up for any questions. So I think just to maybe rewind, it's been shown to have liver transplant's been shown to have a mortality benefit once your MELD goes above 11. So any patient with any features of decompensation should have a transplant assessment at least considered, or at least the conversation should be broached, and a referral to a transplant center be considered once that once they've got features of ascites, any grade of encephalopathy, or recent varicose bleed, or high-grade varices. unless obviously there is a imminently reversible condition, such as potentially viral Hep B going on to your nucleoside antagonist, which can then manage and treat and often reverse that process. So that should be the trigger to pull. As you pointed out, any patient with acute liver failure, and this is not a patient that we want necessarily sitting until their grade 3 encephalopathy with INR more than 1.5. There needs to be some degree of runway in order to stabilize these patients for liver transplant. And sometimes what happens is that we get these patients that already have been encephalopathic and qualifying for transplant workup, and it's the last thing that's activated as opposed to one of the first. And often the patient's just too unstable for us to do all too much for. What else was there? Any other questions from anybody else? I know it's already past 7. The various evaluation aspects that we go through as part of the workup, that's very much a matter of trying to make sure that the patient survives the liver transplant. We don't want individuals who are transplanted and then you find something that's going to have a shortened 5-year survival. You're looking for pulmonary fibrosis, you're looking for ischemic heart disease, diastolic dysfunction, especially with your MASLD patients, cirrhotic cardiomyopathies, and obviously then a malignancy workup. And the malignancy workup really just follows your standard recommendations for screening. So it's nothing all too out of the ordinary. The psychosocial assessment, obviously very important, making sure that the patient has the capacity to take their medications, which can be quite onerous. I know various prophylactic regimes differ. I'm not sure exactly. I think the Cape Town unit uses a cyclovir and INH prophylaxis, which we don't do up here. I think I saw Liz online. Liz, is that accurate to say?
We use Volsite as well, and some patients would get INH prophylaxis, but obviously we
Not
do.
all.
Yeah. I
Okay.
mean, some people wouldn't tolerate it, etc. And it also wouldn't be, I don't think it's long term, but there are patients who've been put on it.
Yeah, so we tend not to use INH routinely, and then we're on a preemptive regime for Valsite prophylaxis. There was a recent consensus document that seems to be lending its weight to a preemptive strategy. The preemptive strategy essentially is where you are not putting them onto Valgan cyclovir therapy and seeing what does the CMV viral load, what does it do? Thoughts behind this is that the natural immunity with you keeping an eye on things is often better, and the body tends to control it as opposed to treating the majority of patients. The patients that are particularly susceptible to CMV reactivation, we found often would just reactivate after 3 months anyway. They used to call it the 12-week fever because these patients would just, as soon as you stop that prophylactic period, flare up their CMV anyway. And you'd have to then treat them. And in those patients, it's not that all of them do it, but so you can't even do a semi-preemptive strategy with them either. And so those are the reasons that we move to a preemptive strategy. It's just really the super high risk ones, those that have received B-cell depletion with rituximab, that we make sure that they stay on a prophylactic dose. Anyone else with any other comments? No, doesn't look like it. Well, Sipho, thank you for the presentation tonight. I hope it was it was valuable in terms of putting it together. I just want to see there is what's next week's. Next week is going to be drug-induced liver injury. It's going to be with Simon Veenstra, and that discussion will be facilitated by my colleague, Dr. Neliswa Gokela. So looking forward to seeing everyone on the 19th. Thanks, everyone. And thanks, of course, to Karen and Gastro Echo for putting this together.
Thanks very much.